So yeah, thanks for allowing me a little time here to talk. I think by now most people have heard that there's been pretty revolutionary changes coming for, January 2023. I would say just as an offset that through the end of the year, nothing changes. So you still have to document everything the way you're doing it now through the end of the year. But with January comes pretty big changes. So um, can we just go to the next slide if we could? So actually, yeah, the next, perfect. So the big things coming are, in the past it used to be this big kind of complex milieu of, having a history, present illness, physical exam, review systems, past medical, family, social history, robust medical decision making, all to get included into the final chart so that we could code it. As of January, most all that has gone away. There is no need per se from a billing and coding standpoint for history, present illness, for physical exam, for review systems. None of that matters anymore. It's all based on medical decision making. This is kind of I know it's kind of a busy chart, but this is our new kind of coding Bible. You can kind of see it's broken up into three columns where number of complexity of problems addressed, the amount of data complexity and data reviewed, and then risk of complication of morbidity or mortality of the visit itself. So basically, if you look down into moderate or high, which are our old level 4s and 5s, you need 2 out of 3, and the highest 2 out of 3 of those specific columns will meet criteria for what the code that we can use. So let's go down to the next slide. Because of the time, I'm going to go into this a little bit more extensively in today's meeting. So if anybody's there, we'll kind of break this down a little bit more. But I am going to, you probably already seen some, blasts. I'm trying to make these email blasts that you'll see in weekly reports and or in separate emails pretty short and succinct so that it's not going to be like you're reading a volume of information trying to ascertain what's important. I'm going to really try to make it short and sweet, but please open those documents when you get them and pay attention to them, because it will have drastic consequences from a revenue standpoint if we don't abide by them. So these are kind of the pearls that we're going to talk about a little bit, and I'll just go down these. There's like 10 pearls that I've listed. First of all, you really want to document appropriate consideration for admission and escalated level of hospital care. This is one of the biggest ones. So the concern is there's going to be a little bit of a leak from levels where, if you look at 3, 4s, and 5s, I think that if you look at what we anticipate going forward, the good news is we're probably going to see more 4s than 3s because there's going to be some attrition there. But our concern is there's going to be less 5s and more 4s on the back end because it's going to be high. It's going to be really difficult to document that high level of risk. This is one of the biggest ones that we can document that's really going to help with that, and that's consideration of admission. And I'm not talking about, patients high level trauma and they're going to get admitted. I mean, that's a no-brainer. And we're talking about those patients that really were riding the fence of whether or not they needed to be admitted or not. And some of the examples that we use are, the COPD or the asthma patient that got several nebs and got maybe continuous for a while, but is kind of, deciding whether or not that patient needed to be admitted. We want to see documentation along the lines of, patient receives serial nebs, seems to be doing well. We discussed admission to an observation versus admission versus home. At this time, feel patient safe for discharge. Those are the kind of verbiage that we're going to need. A chest pain example would be that, patient presented with chest pain, their heart score is 2. We feel that, we had a crucial conversation, and because of the low heart score, I think the patient is okay to go home versus inpatient stress testing. Though, we discussed the social determinants of health. I do believe this patient will be able to, continue antibiotics at home and follow up closely as an outpatient. Those are going to be really critical things that you document. Kind of the second bullet is, did you discuss management with other providers? And we do this a lot in practice, but maybe not so good at documenting it? Meaning, did you talk with social work? Did you talk to the GI guy about, a endoscopy inpatient versus outpatient? Did you talk to the primary care doctor about close follow-up, or a hospitalist of the admitting team? Anytime that you discuss management with another provider, and it doesn't have to be physician per se, you want to document that. Down to the third bullet would be document of independent interpretations. This is also going to be one of the most critical things that we can do. Now, things that kind of follow under that criteria would be EKGs, rhythm strips, x-rays, CAT scans, ultrasounds. The important thing to remember here is it does not have to be a robust, if you review a chest x-ray, for example, you don't have to get a interpretation that would match the radiologist interpretation. You can say something as simple as independent interpretation of chest x-ray showed CHF, showed left lower lobe pneumonia, showed pneumothorax. Something as simple as that document, but you have to say independent interpretation. So that's going to be real key going forward. If you could hit next slide. So documentation or review of external records. This is also new. So this can include run sheets. It can include transfer records, DC summaries. It can include tests like prior stress tests, echo results, prior lab values. The one thing that it can't include is prior ED records or records involved in the same TIN or tax identification number. A lot of us will review prior, EKG or prior ER stays. That's great. And I mean, we do that for good care, but unfortunately, the prior ED record won't qualify for that review of external records. So anything else besides the ED records, please document that you did review those. The next bullet point is document diagnostic tests appropriately considered, even if not ultimately performed. So we get credit for each test that we order and review of those tests, but we also get now credit for actually using our brain. So if we're using the PCARN study and you decide that the child with the mild head injury really doesn't need a CT, we actually get credit for not ordering that CT. Same with Canadian head CT rules, same with PERC rules. So if they PERCed out, the reason they don't need a CAT scan of their chest is because they're PERC negative. We get credit actually for not ordering that. So anytime that you're using those quality measures or decision-making tools, important to document that in the medical record. The next bullet point is document meds given and routes. We've always been pretty good at doing that. But we also want to document prescriptions provided and or considered. Here's another way we get credit for discussion of maybe why. Example here would be, you see a kid with bronchitis. You can say discussion with parents about feel that this is viral in nature, antibiotics would not be beneficial. Well, we get credit for that. We also get credit for review of home medications. So here is an example would be that or changes or discontinuation of medication. So an example would be that you see a hypertensive patient that maybe you increase their home Norvasc from 5 to 10 milligrams daily. That would give you credit. But also if you say patient presented hypertensive, your routine care, yada yada. But I did review patients on Norvasc, lisinopril, metoprolol. I did not change those medications. Now feel stable to follow up their primary care doctor with serial blood pressure readings at home. Something along those lines that tell us that you were involved in prescription drug management. Next bullet. Or next slide if we could. Yeah, okay, so you want to document if history is obtained from any independent historian. Now this has to be pertinent information. It can't be just, wife at bedside agrees with patient's history. It can't be that. But if they can provide something that maybe the patient can't themselves provide, then you can document that and get credit for it. You also want to document chronic illnesses that impact care. And here may be, we all see the cellulitis, but cellulitis in a 25-year-old healthy person is a little bit different than a 85-year-old diabetic with peripheral vascular disease. So if they have concomitant chronic illness that could impact care, you want to document that. This kind of parlays into, care affected by social determinants of health. This is a new criteria that maybe you haven't been aware of in the past, but we get big credit for going forward. So this deals with, is there any issues that involve their homelessness, their poverty, if their ability to access care, do they have care? How did that impact their care that you're providing here in the ER? And again, you see a patient that has, diabetes and cellulitis. I'll use that example as well. But they're really homeless and they don't have any ability to get to a pharmacy or any money to get to antibiotics. So maybe we treated them a little bit different. How did those social determinants of health impact the care acutely? The next bullet point would be discussion of test interpretation with external physicians. Here, examples would be, did you review a CT and it was ambiguous? They gave you the big hedge and you had to call the radiologist and you further discuss their care. Or, did you see a kind of an odd EKG and you ran it by radiology, cardiology? Little things like that where you discussed interpretation with an external physician or a qualified health professional. You want to make sure and you want to document those. Next bullet. Next slide, if you would. And I know we're rapid firing these, but I wanted to at least kind of touch base with you and still allow time for a few questions. So here's a quick example. So, you see a 39-year-old patient, chest pain, wheezing, shortness of breath. You do your typical history and physical. You order some labs, EKG, chest x-ray, give them a neb treatment. Next slide. And your documentation may look something like this under previous medical decision making. EKG and chest x-ray normal, labs are unremarkable, reevaluation, patient stable. You gave them an albuterol inhaler to go home with and follow up with a primary care doctor. That in the past was probably enough to give you a level 5 chart, but as you can kind of see with the next chart, or next slide, please, you can kind of see that this is where we really worry about that slippage of a level 5 to a level 4. So under current guidelines as of January, that same patient, the presentation is probably going to be high level. So you're going to get, that's going to be column 1, you're going to get high level. But the way it was documented that I presented, you did your basic labs, you reviewed them, chest x-ray, EKG, and you gave them albuterol in the department and you sent them home with albuterol. That's considered prescription drug management. But under the new guidelines, that's a level 4. So things that you would potentially do to buff that chart up or documentation that maybe you weren't doing in the past that we actually need to do now would be, so for high level of, for the data review, we need 2 of the 3 criteria. So in addition to the labs ordered and reviewed, you need to see something like chest x-ray was independently reviewed and did not show any infiltrate, or EKG showed sinus rhythm, no ischemic changes. Something as simple as that will give us that second criteria, 2 out of the 3 to meet for data. Then you have between data and problems addressed, 2 out of the 3 to meet high level. If you could parlay that again in the third column of risk, where the patient's reevaluated, seems to be doing much better, don't think that admission to the hospital is required at this time, you could get criteria for that as well. So that was kind of the things that you need to think about, and the reason that we're going to be harping on you to document those kind of things is to capture those level 5s that we're really worried about losing to attrition with these new guidelines. So, we're already looking at fairly significant Medicare cuts going into 2023. It's been estimated that if we don't change our documentation guideline or our documentation practices going forward, there's been estimates of 3% revenue loss on the low side, up to 11% of revenue loss on the high side by not adopting these new practices. So it will be very critical from a revenue standpoint to really try to abide by these. I know that's kind of the real down and dirty, rough thing. I will say, Trevor, we've been working with Trevor. I'll let him comment a little bit, but there are certain things that we can do in the medical decision making to provide we talked about doing dot phrases, we talked about hard stops. There are some things in Epic that will allow us to capture some of these. So we are working with Epic to try to instill some of these into the medical decision-making process that won't necessarily be hard stops, but will give you kind of reinforcement to remember some of these things going forward. So I'll stop there. If there's any quick questions, please fire away.
Hey, Don, I have one. Can you explain, actually put up the PowerPoint again? So what happens if you get level 5 in that first column, level 5 in the third column, but again, only 1 of 3 in that second column? How does that work versus 2 of 3? Is it like an in-between place, or is it built to the lowest level?
It's built to the lowest level. You need 2 out of the 3, and 3 out of, and again, the column 1, 2, and 3, those are the 3. So you need 2 out of 3 of those columns to meet high level. But if you look, it can be a little bit confusing. If you look at just column 2, component 2 data, to meet, there are three categories there. Categories 1's test documents, independent historian. Category 2 is independent interpretation of diagnostic test, and category 3 is discussion and management. To fit that high level, you have to have 2 out of the 3 of that as well. Does that make sense?
Yeah, so there's not like a 4.5. It's not like if you get component 1 and component 3, but you miss component 2, like you just get a level 4 chart. Like you miss out, right?
Right. You need, again, with the columns, you need 2 out of the 3 columns. The highest level will determine the highest level that we can build. I know that was down and dirty. Again, I'm going to try to, what we'll do is, in the weekly blasts, we'll try to take each one of those and break them down a little bit and kind of give examples of what we're thinking and ways that maybe you can remind yourself, things like that. And again, I think that what Trevor's doing with the MDM and the EHR is really going to be helpful as well. Again, it is going to require a little bit of extra time in your charts, but again, it's one of these things, don't kill the messenger. We just have to abide with what we need to do to capture revenue. And, you know, this is fairly revolutionary. We haven't had these changes. The guidelines that we have now were instituted in 1995. So we've had the same documentation guidelines for 27 years. That's drastically changing now. So, you know, I understand it's going to be painful and it's going to be a learning process, but it's something that everybody in the industry is going to have to deal with. And again, if we don't, it will affect our bottom line and our revenue stream.
Don, should we expect any type of an audit or anything from MMS to look through some of our documents and give us feedback if we're missing like the same thing over and over again? Kind of like we used to do.
That's a great question. So what we're going to do is we anticipate some of the misses are going to be misses by everybody. So we're going to globally look at these by 10, first of all. You know, ECS has several 10s, and we're going to track pre and post implementation of the guidelines acuity levels, because that's going to be the best way to do it. And, you know, in a perfect world, we should see an uptick of 3s to 4s, and we should see our level 5s stable. If we see a real drop off in level 5s, then the first thing we're going to do is, you know, because you can imagine there's a lot of data there. We're going to attack it by 10, seeing that, you know, the northern 10 looks like they're the ones that are losing the most revenue. So then what we'll do is we'll go to break it down by hospital and then break it down by provider. But yes, the goal is to look at these at a macro all the way down to a micro level, looking for ways that we can improve. Yes.
Thank you, Don. Does anybody else have any questions for him?
Thank you, guys. Great seeing you. And again, if you're going to attend today's lecture, we'll kind of dive in things a little bit more in depth, but appreciate it. I'm always available. If you have any questions, please feel free to reach out to myself. Charlie Searzant and Andrew Klein are also kind of mentoring into the reimbursement process. So if you have any questions, you can reach out to them as well, but happy to answer any emails or questions. But again, please remember, take a few minutes each week to look at those blasts. I'll try to make them short and sweet and adopt them into your EMR. Thank you so much.